This
Not
conference
quite
will now be
out of breath
recorded.
not quite as out of breath as I've been, and a little more stamina and so forth. So I was certain that the Procrit had kicked in, and my red count and hemoglobin and everything was up. But to my surprise, it was still about the same. It has hardly budged at all. And so I think it does take longer than it's been about it's been a little over 2 weeks now since the shot, and it probably takes a longer time. So yeah, that was a big surprise to me, because I was certain that I was going to be less anemic, but I'm still pretty darn anemic. And yeah, I'm wondering. I know my dad was anemic for most of his life, and I'm wondering if it's a genetic thing, or it's just attributable to the ADT and the cancer and so forth. I don't know, but there's not much I can do about it. This is my first action to try to counteract it, and I've got a meeting with Dr. Turner tomorrow, a telemed meeting, and that's one of my questions is, after chemo, am I going to stay on Procrit to try to counteract this anemia, because it's always kind of lurking, never quite as low as it is now, but it's just been in the background all the time. So I don't know if anybody else is fighting anemia or not, but it's just been there for me all the time, a shadow. That's pretty much it.
Len, do you have any idea how the Procrit works and how long it might take to kick in?
Well, it's a naturally produced hormone by the body to step up red blood cell production. So this is like what they call a biomimetic. It mimics a natural hormonal substance. I don't know how long it typically takes. I'm just thinking the power of placebo, because Peter, you said you thought for sure that your anemia had improved. You were feeling better, stronger. Power of placebo, it's amazing.
Yes.
I don't know how long it should take. It wouldn't be instantaneous, that's for sure. I would imagine it would take a couple of weeks to ramp up red blood cell production. It's not like getting an infusion where all of a sudden, you've got an extra pint or more of red blood cells. It doesn't work that fast.
Yeah, I think Turner will probably have an idea, because he was the one that told me I should have gone on it a couple months ago. So he probably knows how long it takes.
Mm-hmm.
Yeah.
Mm-hmm. Peter, did you see that article that I sent it to Len, and I think I did send it to you, and I sent it to Ken, about carboplatin?
Carboplatin?
Yeah.
Of course. Yeah.
Given with docitaxel, it seems like there's definite advantages to carboplatin being given with docitaxel.
Yeah, and that's what I've been doing. Yeah,
right.
So number five is Friday. I think I mentioned that I'm not taking quite as much. I took the full dose. There's a dosing thing. It goes 1 through 5. It's called ACT or something like that, a scale. And I was at 5 initially for the first couple, I think, and then now I'm down to 3.5. I'm not. Turner suggested I don't take the full amount for whatever reason he was thinking. He said he usually doesn't give the full dose of carboplatin. So.
Mm-hmm. Well, I don't know if this is a recent study, and it's interesting because it was given at an AUA conference, and not at ASCO. But I wonder if you might want to draw his attention to that study. Ken, did you see the study too? I'm pretty certain I sent it to you about doing carboplatin with docitaxel.
No, I didn't read it, so I don't think you did. But
I
I'll
know,
look through your emails and see if
yeah,
it's there. I don't
I
remember
know,
reading it. Oh,
I know I sent it to you because Len joked with me who was going to send it to you, and
oh,
I said I would, and I did.
gotcha.
It was about a
I
week.
also did receive it.
Did I send it to you too, Carl?
Yes.
Okay. So look for it. If you can't find it, I'll send it to you again. But I definitely sent it to you because I knew that it was going to be very appropriate for you. This was an AU. Len, do you have it open in front of you by any chance?
No, sorry, I don't, Rick.
All right, now I'll find it. So
But can I just jump back to Peter for 1 second? I just did a quick search on how long it takes Procrit to raise red blood cell counts. They said 2 to 6 weeks. So when did you get your first shot, Peter?
A little over 2 weeks, about 2 weeks ago. 2 weeks ago today.
Oh, yeah, that's a little too early to see an effect.
Okay, I'll get another shot on Friday.
Okay.
So, one of the nicer things about having a small group like this is that we have a little bit more time, so we can sort of look around for stuff. So what I'm just doing right now is I'm just looking around for this docitaxel+carboplatin study. It was a poster at AUA in April. That much I remember from memory. Here it is. Okay. Addition of carboplatin to chemotherapy regimens for metastatic castrate-resistant prostate cancer. It was from the Journal of Urology. And I'll just read the conclusions. It says our data demonstrates improved cancer-specific survival in treatment refractory metastatic castrate-resistant prostate cancer, that's mCRPC, with carboplatin plus Taxotere when compared to Taxotere alone, and when compared to cabazitaxel alone. It does say selection bias is inherent in retrospective studies such as this. However, our results would suggest providers consider carboplatin plus Taxotere in the late mCRPC setting after failing second generation ADT. I'm going to put the link in the chat window because Peter has it and everybody else is on the okay.
What's the survival benefit, Rick?
Let's see if it was, I don't know if that was, I don't know if overall survival was a measure, but take a look. I'll tell you what, here's your assignment, Jake. You take a look right now and you can report back to us what the survival benefit was in half an hour. Okay, so we report 30-month cancer-specific survival of 37.5% and 30.9% for carboplatin, for Taxotere and cabazitaxel, and 66.5% for docetaxel and carboplatin. So again, they picked 30 months arbitrarily. You don't know how sick these people were going in, so it's not To me, that's not a great measure. What's important is that it was twice as good. Whatever the measure was, it was twice as good. So the healthier you are when the start, the better you're going to be if you add the carboplatin. So it's worth asking people. Let's go quickly to Carl. Carl, can you hear us?
Yes, and you can hear me now. You can hear me now? Okay.
Yeah, you said you've got to jump off pretty quickly. So did you have anything that was on your mind?
Well, I guess based on the study you have forwarded to me, I guess my concern is it's to the extent that it might be toxic to just have docetaxel by itself. I would expect by adding another chemo together might make it that much more difficult to tolerate.
Yes, the answer is yes, but the answer is also that we have somebody doing it right now on the telephone who was docetaxel naive. So, Peter, how do you feel about adding the carboplatin and I mean, how bad has the docetaxel been?
Well, right now, I mean, the first 8 days kind of suck. But the last week is pretty good. So I can't make a comment on that because I've never done one alone. I seem to tolerate it pretty well. I wouldn't say it's twice as bad, or it couldn't be. I think it's just what it is, and it's all I know, and it's not terrible.
Mm-hmm.
And which one are you taking, Ken?
I'm just doing docetaxel, a taxane-based one. I'm not doing, the others. So based on how I handled the last, I did 6 rounds about 2 years ago, and I handled it pretty well. But I'm going to send a message to Paul at MD Anderson and ask the question, one, whether or not he's reviewed that, note and see what his comments are. I hate sending him something like that because I don't want to give him homework because I think he has enough homework. But I might just ask him the question, what his thoughts are about adding it. So I don't know. Maybe I can report in a week because he's usually pretty good. I need to send him a report anyway and let him know how I'm doing.
Barbara, yeah, sounds like Barry isn't doing that well on carboplatin, on the cabazitaxel right now, though.
We're going to find out more on his blood test tomorrow. He's only had 2 rounds of it, and I know that flares happen, so sometimes this resolves itself. But the fact is, when he did Taxotere, the good news is he didn't have a lot of side effects from it. So, I mean, we knew what they were going to support. We were prepared. We iced his hands and his feet, and he didn't get any neuropathy, and that really worked well. And but it also his PSA went down and then up, and his scan confirmed progression. So he went on Xtandi, and the same thing happened. That didn't work either. So he started cabazitaxel about a month ago, and the first thing that happened was his liver enzymes went up, so he had to delay his retreatment and had his second course a month later. But he's also gone up from 30 to 45. So he has another blood test tomorrow, and we'll see what happens. To be honest, I don't expect it's going to go down. I think we're looking, as you know from our conversation, Rick, at this point, we're looking at other options from him, specifically if the foundation one has come out, shows.
We'll come back to the foundation one a little bit later, but what about comparing side effects from docetaxel to side effects from cabazitaxel?
Well, for him, I have only one word: miserable. The docetaxel was absolutely nothing happened. We kept thinking, we were ready for it, but nothing happened. Cabazitaxel, he got exhausted, he got nauseated. The good news from the bone pain is it seems like a couple of Advils a day more mercifully controlled it. So it wasn't like he had to go to anything else, but he's almost hoping that cabazitaxel doesn't work at this point, so he'll have a reason to get off it.
Yeah.
If his liver enzyme is okay, his AST went up to 112, his alkaline phosphatase went up to over 300. So, I don't know what to say. I'll know more tomorrow, but I'm not hopeful. He's got a good sense of humor. He still walks up and down that hill. That's why we were late for our meeting. We went on, did our daily hike in the woods and just came back. But we need it both. We both need that escape. But,
Good. Everybody,
the fact is,
this meeting seems to be a catalyst to get people to exercise. You're the second one who's told us that you just came back from a walk. It's so strange. It's really true that everybody responds differently in that, I know a lot of guys that have had such an easy time with Jeff Tanner. I mean, they've had no side effects at all. And when they've had side effects from docetaxel, and yet we get other people that have a tough time with the Jeff Tanner, with the cabazitaxel. So it's just hard to know. It's really hard to know.
it hit us from that field because we thought it would be a piece of cake like the other one, and boy, did that not happen.
Yeah, I mean, it's pretty rare that I've heard anybody have this situation like you, where the cabazitaxel has been rough, but the docetaxel is not. Len, can you remember anybody who did well on docetaxel, but then did very poorly on cabazitaxel?
No, I don't. I remember Dominic was first on docetaxel, and then years later, he was on cabazitaxel. He claimed cabazitaxel was a lot easier on him than the docetaxel. Also, there was a study, it was even a crossover study where they put guys first on one drug and then on the other, cabazitaxel or docetaxel, 70, and then they questioned them regarding quality of life, and 70% said they would choose cabazitaxel over docetaxel. But 70%, that means 30% didn't feel that way. So I guess Barbara's husband is in that group.
Yeah.
I think Jim Harrington might want to try both, Rick, but I don't remember exactly.
Yeah, I think you're right. I think Jim Harrington did try both, but I don't think we can ask him.
Unfortunately, no.
No. I can look back in my notes and see what he said at the time, but I'm not going to do that right now.
Rick, I wanted to just get back to Carl for a second. I think we might be crossing two different studies. The interview that Chuck Ryan conducted about PARP inhibitors and BRCA, when they mentioned platinum-based compounds, that was not meant to be in addition to olaparib. It was meant to as an alternative, because Chuck Ryan said, well, we automatically put everybody with a BRCA mutation on olaparib now. It says, but maybe we should be considering some other drugs, and that's when the topic of platinum compounds like docetaxel and cabazitaxel came up. So you wouldn't want to be on both of those at the same time, I wouldn't think, because they're both immunosuppressive.
Myelosuppressant.
Myelosuppressive.
Yeah, Carl is. Look, Peter, we need to mute you right now because we're getting feedback off of you. Jake, could you take care of that? Thanks. Carl has left, but he sent me a note and said that he would listen to the replay when we post it. So he'll get your message. He had another meeting that he had to jump on to. And John Hall, welcome. John, do you have anything you'd like to talk about today?
Just briefly.
Okay, I'm giving you a tick, and I've got a tick for Barbara. All right, so let's talk to Paul Frieda, who always gets squeezed out. And on my bike ride today, I thought, I'm not going to let Paul Frieda get squeezed out. Paul, are you there today?
Yeah. I just had to take a phone call from my brother. So a couple weeks ago, I heard someone say that if you've been on ADT, you definitely should get a bone scan because it tends to cause osteoporosis. Is that correct?
Yes.
All right. So I requested my med-onc to give me a script so I could do it, and he refused. I refused is a strong word, but he said I was suggested that I go to my general practitioner to do it. Isn't that a little strange?
Well, I think, I would go back to him and say, Doc, we know that ADT weakens our bones, and its protocol, I think it might even be NCCN protocol. I'll let you do the research, but I think it might even be NCCN protocol that when you put a man on long-term hormone therapy, as you were, not now, but you certainly were,
3 years.
that you should measure bone density at the outset.
Oh, I mean before you start?
Yeah, because and I'm the sort of the poster child for that, because when they measured my bone density, I was borderline osteoporotic. I mean, I said I was beyond osteopenia. I was right on the borderline of osteoporosis. And so they gave me 3 infusions of Zometa over 2 years.
3 infusions of what?
Zometa.
Zometa, yeah.
Yeah. Over
how long were you on the ADT?
2.5 years.
Okay.
2.5 years. But they saw that I was osteoporotic at the outset, so they did it prophylactically.
Okay.
Paul, did you ask for a bone scan or a bone density scan? Totally different things.
Good point. I might have said bone scan. Yeah, I might have said bone scan, not bone density scan.
Yeah, but I'm sure he understood you correct to mean bone density, because if it was a bone scan, he certainly wouldn't have sent you to a GP.
Okay. All right. So you don't think he misunderstood?
No.
I don't either. I mean, because normally it is your GP who would order that. But if a doctor is prescribing hormone therapy, he should have no problem in ordering a bone density scan for you to make sure that your bones are strong enough.
Well, I'm sure I didn't have that scan. Well, okay. He might have when I had my surgery, they did a bone scan.
That's a bone scan. There's a difference. A bone scan is looking for
Mets, right?
Mets, exactly.
Yeah, and if I had Mets, then they wouldn't have done the surgery.
Right.
Hopefully not.
Well, they may have done today. They may have done, as Carl had it, but when you got it done, they would not have done it. No. But that's looking for Mets. What we're talking about here is how strong your bones are.
Bone density scan.
Right.
Think I should go back to him and talk to him again, or should I just go to my GP?
It all depends if you want to educate him. If you want to educate him, yes. If you don't care, then go to your GP. And the thing is that for men over 65, I think it's covered by Medicare anyway, because unfortunately, a lot of doctors don't recognize that osteoporosis is a disease of men as much as it is as women. And so they don't order it. And you as a man have to ask them to order it, to do it. I mean, they should. I mean, as Barbara will tell you, for most women, the GPs will order it automatically when you hit menopause. But for men, they just don't do it, and they should do it.
Yeah.
Rick, just to add to what Paul said, I had the same experience with my oncologist. He wasn't interested in having me get a bone scan, but my wife, she sees the same GP I do, and she talked to him about my situation, and he had absolutely no problem ordering a bone scan for me.
A bone
Of course,
density,
I'm on Medicare. Pardon?
bone density scan.
Bone density. I'm sorry. Yes, bone density.
Yeah. So, Paul, it's up to you. You know, if you want to fight the fight, go for it. If it were me, but then I'm sort of I'm an advocate. I'd go check the NCCN guidelines and I'd see what the NCCN guidelines say. And if the NCCN guidelines say you're supposed to you're supposed to order it, then I'd show that to your doc. I do remember my urologist telling me at the time that he put me on that if they put men on for more than 12 months of ADT, then they automatically order a bone density scan.
Yeah. Okay. All right. All right. Well, the other question I had is that I got a lot of itching in my hands. It's really annoying. Is that something that's typical for people that have been on ADT? Anybody?
Anybody want to take a shot at that before I answer?
Was that itching?
Yeah, itching in my hands, and it's really annoying. So what I do is I go to the shower, I turn it on as hot as I can get it, and I sort of like burn my hands, and then it goes away.
Well, I've heard of people on ADT do complain about dry skin. Have you tried using moisturizer cream on your hands?
No, it feels like it's coming from the inside. It really doesn't feel like I'm dry or anything like that. But it could be. I mean, I don't use any moisturizer on my hands. You think it could just be a surface skin problem?
Possibly.
Well, I've been on ADT for 8 years, and in the last 6 months I've been itching like crazy. Not just my hands, all over.
Yeah.
My skin very noticeably dry. So, and I've been using like Len suggests, using a moisturizer, and it does help, but I still itch.
Well, I have to say I also get the itching on my ankles.
Yeah.
And I'll stick under the
same here. I'm on ADT and I get itching. I do use the lotion quite a bit and more muscle fatigue than anything. But you get itching, really nothing in the hands, but everyone's different.
Okay.
My pharmacist suggests using a moisturizer with oatmeal in it. I think it's made specifically for eczema, but she said specifically use one with oatmeal.
Okay. Thank you.
Are you saying oatmeal,
Oatmeal.
Jake? Oh, okay. I wasn't sure if that was opium or oatmeal.
No, oatmeal.
Oatmeal would
It
probably
works
work
good
well
for
too.
any kind of inflammation.
It might be better with opium.
I don't know. For oatmeal, it might be good for breakfast.
Hey, Ken, don't go anywhere. I wanted to ask you something. Before I forget, because I know Dennis Korea likes to tell folks to use TheraWorks for muscle cramping, and you had muscle cramping. Did you try TheraWorks? Did it work?
No, I started taking magnesium tablets, 800 milligram magnesium tablets, and that took care of it. I actually cut the prednisone to half as well. I cut it from 10 to 5. And Paul said it's not uncommon to get muscle issues. I also, so those are two things. I never tried it though.
Okay.
Okay.
I must admit, your skin does dry out after being on ADT for a while because my legs get. I mean, I put lotion on my legs and arms, even my hands.
Okay. All right, I'll try it.
I use an aloe-based hand sanitizer that I put on.
Okay, Mr. Frieda, are we caught up?
Thank you. Yes.
Whilst I've got you, how's your daughter doing?
She had her 14th birthday on Sunday. She's doing fine.
Good. Good. I'm pleased to hear that. I'll give you a call, but I'm pleased to hear that things are settling down a little bit. And how are you doing?
I'm not in good shape. I can't get over it right now.
Yeah.
For those of you who don't know, my wife died suddenly of a brain hemorrhage in January, and she was like a soulmate, and so I've had a real tough time getting over it.
That sucks. Sorry, man.
Hang in there, Paul.
I just take it one day at a time.
That's the way to go, Paul. That's the way to go.
On top of everything else, you have that. So, man.
Yeah, and COVID virus.
Yeah, it's a shit. So far, a shitty year.
Yeah.
Paul,
But hey,
put a note on your calendar. Put a note on your calendar to join us on the Speaking Freely call. And actually, Rich Jackson joined us. Rich, are you with us? I see your microphone's off. Can you make that red microphone turn green? Well, he might have stepped away. So Rich moderates that meeting. It's really a good meeting. And Paul, it would be great if you would join us on that meeting. It's
When is it?
It's on the 18th this month. It's the third Thursday of the month, the 18th of June at 8 o'clock your time.
I agree. It's a great meeting.
It really is.
8 p.m. on the 18th. Okay.
Yeah, try and join us.
I will.
And maybe you can unload a little bit on us, and that'll help you. And you're really welcome to do that.
Rick, let me interject that the meeting is nothing about treatment. It's all about feelings and what we're going through. So I highly recommend it, like Rick said.
Yeah, we try to stay out of the treatment issues. Are you back yet, Mr. Jackson, to do your promo?
Well, you were doing such a good job. I just was taking notes and listening.
Well, what would you like to add? What would you like to add, since we now hear the mellifluous tones of Rich Jackson?
Well, as Russ and you pointed out, it's a non-technical visit with everybody that would like to attend. It is, Barbara, I'm sorry, it's men only.
That's okay. I'm in a lovely women-only group that's parallel, so I'm okay.
Fair enough. But it's whatever is bothering you, whether it's tragedies from a medical point of view, from a personal point of view, from the world in general, the standard rules apply. Politics are out, religion's out. A bless you is perfectly acceptable, but if you start breaking out wafers and holy water, then we draw the line. But third Thursday, 8 p.m., the same connection that you used to get here, 8 p.m. Eastern.
Okay.
And would be happy to have you stop by, and if pretty much you can say anything that you'd like to say, and it goes no further. We don't record, we don't allow it.
Right. Thanks. And it's pan-cancer, so sometimes there are guys with other cancers in there too. Rich, whilst I've got you, would you like any time today?
Doing fine, thank you.
Okay. All right, well, we're going to move on, and let's go to Ken Anderson. Ken, just a quick update on this round of chemo.
Yeah, there's really not much to say. I completed it about a week and a few days ago. Didn't have any side effects. I mean, I've done it before, so I was pretty prepared for, this particular journey. So I did get a new Lasta boost, which I wasn't sure I was going to get, but because I was flying the next day, they kind of pushed for new Lasta. Um, what else? Yeah, I don't really think I'm going to have any issues. So I did want to make a note. Peter, did you finish your third round or was that your fourth round?
Your fourth round.
Number 5 is coming up on Friday.
Okay, wasn't sure if it's three or
I just
four.
wasn't sure if it's 3 or 4.
5.
Well,
5 is coming up on Friday. Yeah.
Yep, lots of luck.
Yep, lots of luck.
So, Len, when you made your comment, of course, the reason I was away from the TV, away from the screen is because I had leg cramps.
Mm.
I did a hike around Mount St. Helens, and
Oh,
but it's self-induced. It has nothing to do with anything other than my own eagerness to go for a hike. So
okay. Well, good for you.
the bone scan, I must tell you, I got a cash price going to the scanning center. It was $55. So if anyone wants to do it, just go and negotiate a price with them. It's an inexpensive scan. I'm sure if you ran it through your insurance, it'd probably be $300 or $500. But the cash price for the place that does the scan, at least in Phoenix, it was $55.
What scan was that,
So,
Ken?
the bone density scan.
Oh,
Oh,
okay.
Yeah. Yeah.
Ken, can
So
I
that's
just ask?
about it. I don't really have anything else on myself, just hiking and fishing and kayaking and playing in the rain.
Ken,
Going
can I
back to
just
Phoenix
ask?
on Wednesday for round 2.
I just wanted to ask if I can
It,
quickly. Ken is talking about third or fourth round of chemo.
right?
Is that correct?
Is that correct?
Well, Peter's going for his 5th.
Peter's going for his 5th.
Yeah, I'm just wondering because I'm getting ready to start my third, and I'm wondering. I'm getting a lot of feedback. I don't know why.
Okay, I'll turn off my
Peter.
mic.
There you go.
But I wanted to know, in terms of my journey and down the road, how I would expect to have third and fourth rounds or fifth rounds of chemo. How does that happen? How do you progress that way to get to that point?
So let me just clear terminology here. So when Peter says he's doing his 5th round, it means he's doing his 5th cycle the first time he's doing chemo. Okay.
Oh, okay. Yeah.
So
Okay.
he's in his 5th cycle. He's about to start his 5th cycle of his first round of chemo. Ken Anderson already did, I think, 6 cycles, and now he's doing a second round of chemo, the same chemo. So these are not. Does that, first of all, does that clarify? And then, what do you have a follow-up question?
Yeah. I just, that clarifies extremely well. I guess so. So I can expect that possibly I'm going to do docitaxel here in about 3 weeks. So, and it's 6 cycles. But it's not like a one-shot deal. I could expect possibly to do that same chemotherapy again at some time in the future.
Absolutely.
Okay.
No, and it's fairly unusual to do what Ken's doing, which is to do the same one. They may switch it up a little bit or change it. In Ken's case, they haven't.
It's usually cabazitaxel is the second one?
Yeah.
Or is that, okay.
But I also recommend that you show that journal article to your doc and ask him what he thinks about adding carboplatin.
Okay.
That's what that point is, that you're better off with docetaxel and carboplatin up front than docetaxel alone. I don't want to say up front because we don't know enough about the history from the abstract that we have there. We don't know enough about the history of the people. What we do know is that they were castrate resistant metastatic. You're not castrate resistant.
Yeah, I'm still hormone sensitive.
You're still hormone sensitive, but I still think it's worth sending that over and showing it to him. And he may come back and just say to you, yeah, well, that's not you because you're hormone sensitive. But I still think it's worth showing it to him. If it were me, I would.
It's called carb. What was it called? Carb or what?
Carboplatin.
Carboplatin. Okay.
But go to, click in the chat window on that link. It'll open up in your browser, and then you can send him the link.
Okay.
In the study, Rick, there are approximately 30 people out of 172 had previous docitaxel, and about 90 of them had not. They were chemo naive.
Right.
So.
Right. But they were all metastatic castrate resistant, correct?
Yes.
I have a copy of the link too. Can we all have a copy of the link to that?
The link is in the chat window.
I can't find the chat window, but I guess I can look afterward. It's not on my screen.
Yeah, there should be a little bubble somewhere.
If you move your cursor, it should pop up.
Yeah, there's a little bubble, and that bubble will open a chat window. And then people send rude notes to each other. You know, like, I wish that Davis would shut up and stuff like that.
Oh, wait a minute, I'm off it entirely now.
Okay.
Oh, wait, I think I'm out of the meeting entirely. Could you hear me?
Yeah, you're still with us.
I think I navigated away from the meeting. Oh, there you are. Okay.
Yeah.
I think I'm going to stop looking for the chat window now. I just lost all of you.
Okay. Well, you'll find it in document. If you look in documents afterwards, you will definitely find it. So.
Thanks.
Steve,
Barbara, Alt tab. You should be able to find your way back.
Which tab?
You hold down the Alt key and then you press tab, and it'll cycle through your windows, and I'll bet you'll come back.
I think
this is not a.
Hold down the Alt key and then press tab several times.
Oh, I don't have one. I'm on an app. I'm on a Mac. So which is the equivalent of the Alt?
Oh, you're on a Mac.
All right,
okay.
sorry.
We can't help you on a Mac.
I think this is. Yeah.
Okay.
That's not it.
Let's move along here. Steve, did you have anything?
I can handle this.
Anything else you wanted to ask?
Yeah, I was just joining in there, but I did have some specific questions. And some people have already commented on this because I'm getting ready to do the docetaxel in about 3 weeks. I've been reading some information about the ice therapy in terms of keeping your feet and hands exposed to ice or low temperatures, and also this thing called an ice cap, which will keep you from losing your hair. I don't know if there's any validity to that, or if anybody's experienced that. Or is it something that I should try to do when I go to the clinic? So yeah.
All of the
My husband did.
Let's hold on a minute, Barbara. Let's let Peter start because he may have to jump off. Peter, why don't you start? Peter? Mr. Kafka, are you there?
I unmuted him thinking he would want to pipe up, but maybe he's not available.
He may have gone, so we'll come back to him in a moment.
I'm available.
He's available. Okay, go ahead.
Okay. Yeah, I couldn't tell whether you guys muted me or not. Okay. 2 things. One is I bought an ice cap and I tried it several times. My hair still fell out. I've got a little bit left, but it's pretty stringy and not much. So I don't think it really does anything. There are some ice machines that are clinically driven, things the hospital actually has where they cool your head and stuff, and that might work. But the things you buy through Amazon or whatever didn't seem to work for me, and I had a pretty thick head of hair. I don't know about doing the feet and hands. I mean, maybe, but I don't think it really does much. I think it's more a nuisance. So I have one other question. I have one other question since we've done a lot of stuff on chemo, and it came to my mind that I haven't heard of any new chemotherapies for a long time. And have people given up on that and have gone to PARP inhibitors and other kinds of drugs, and given up on looking for chemotherapy drugs, or is there anything new in the horizon in that score?
Okay, so Peter, can we finish off with this question around the ice, and then we'll come back to that when we're done with the ice.
Okay.
Barbara,
what did you think?
Barbara, you obviously you mentioned you have experience with Barry using ice for hands and feet.
Yes, I do. He didn't care about whether he lost his hair or not. He didn't have very much to begin with. So I can't speak to ice packs. To be honest, he looked absolutely gorgeous bald. He just looked like, sort of like a movie star style, rather than the scrawny hair he had before. Actually, it was great. So that was not. He also loves mechanics in the garage. I mean, one of the loves of his life is tinkering and inventing. And I read on the advanced prostate cancer board and the metastatic prostate board that several people had used ice on the hands and feet, and they'd had success. So we did it. We first bought the Amazon ones, and they were completely useless. They defrosted, they got hot and warm in like 10 minutes. And finally, we found out that if we just asked the nurse for a pitcher of ice, and we used Ziploc bags, piled them around his feet and hands, and then put a big bag over them, being really careful to put socks on him and cloths on his hands so he wouldn't get ice burn. I mean, it's a delicate balance. And we did that at every single treatment with the docitaxel. And like the other people who reported on that board, he had zero neuropathy. And that would have just been devastating. And it's also worked with the carbazitaxel, which I understand has less neuropathy to begin with, but from everyone I've spoken to, it's good, it's harmless, it's a nuisance. But if you can prevent neuropathy, I think it's really important. That would have been just devastating for him. So that's sort of our experience. As far as the ice caps, I really don't know. That wasn't what my husband wanted.
Yeah, I've heard that.
Does that make
to prevent the neuropathy, because it does interfere with your ability to exercise. So you want to avoid it if you can.
Yeah, it's like you don't. There's nothing much to lose. There's nothing harmful in it. So that's the other good side.
Now I have another question. I know a lot of people here have been on docetaxel, and I'm getting ready to start it here in about 3 weeks. So I'm just wondering, it's kind of a broad question, but how, what kind of side effects I should expect to have, and how you've experienced it. Some people seem to have very little issues, and some people not so good. So just as a general question, is that what can I expect to experience? Anybody that might want to contribute?
Well,
yeah, I'll contribute.
Okay, hold on a second, Peter. We'll throw it out, but as we said when we were talking about this earlier on, Steve, it's so hard to tell. Barbara's Barry had no problem with docetaxel or little problem, flew through and then flew through it, and then had issues with the carbazitaxel. We have a lot of men who have a tough time on docetaxel. Sometimes as early as not the first one, but certainly from the second one. Dennis will talk to you about that. But there are people that sort of hit a bottom around 4 or 5, and then 5 and 6 can be easy, and some people find 5 and 6 tough. So we don't know, but we've got so many men on this call. Unfortunately, probably 4 men, including Barbara's experience. So why don't we start with Peter and then go to maybe Ken and go to Dennis and then Ken. Let's start with you, Peter.
Okay. My experience is the day of infusion, which has no impact at all. I drive myself there. I drive myself home. It's a walk in the park. I don't feel anything. The next day, I don't feel anything either. I'm fine. No change. Still appetite and everything. By the 3rd day, I start feeling like shit. Loss of appetite. I start getting a metallic taste in my mouth. If I try to eat anything, it tastes like barbecued tinfoil, and that goes on for about a week. I open the refrigerator and just nothing looks any good in there, and I just don't feel like eating, and I don't eat much. So that's a whole week, and then you come out of it, and by the last week before your next cycle, you feel great. You're eating again. You got to, if anything, try to not eat so much. They put me on prednisone, and I started getting some odd side effects, and I decided, why am I taking prednisone? I stopped it, and I weaned myself off of it with letting my doctors know, and they were in agreement. There was no need for it. So I do take I take some dexamethasone the day before, day of, and day after, but that's it in terms of steroids. So you get used to that cycle. One cycle has been no different than the other for me. 8 days of feeling like crap, and then I come out, and then I get hit again. I just keep repeating it.
How about afterwards, after you stopped, pretty much returned to as you were before?
Pretty much, yeah. I feel strong, great. I'm alert. I didn't go through the fatigue or tiredness stuff. I don't have that. It just doesn't knock me out, but it just said general malaise feeling. We just you just feel like crap, and you can't. I can't focus on reading. It had one side effect that it's had on me, and I don't know why. It's messed up my vision quite a bit. I don't know whether it's cataracts or what's going on, but I noticed a big change in my vision since I started chemo.
Dennis, would you like to talk about your docetaxel experience?
Sure. I was probably the oddball where it gave me a rough time. Peter's example of the cycle that you go through from one to the next, and you don't feel bad at all the day you get the infusion, and then things start to go, the appetite and so forth. You really got to kind of watch what you eat if you want to avoid the extreme nausea. Steve, just an observation. I think you're enjoying a nice glass of red wine, which I used to love to do. And you may want to consider not doing that during your chemo.
Probably won't have an appetite for it.
Yeah, I've read in several places where alcohol is not something that's going to help you get through chemo at all. But I got halfway through. Now they were not doing, when I started it, they weren't doing the day after shot to maintain the white blood cells, and they didn't have the patch, which they have now. And I got about halfway through and developed neutrophil fever. Physically, you do have a fever, and I called in my doc, and it says, I'm not feeling good. I'm running a fever and everything. They're going to get to the ER. Went to the ER, and they said, they admitted me right away, and the white blood cells are disappearing. They crash. And they eventually got me through it, but during the process, I developed pneumonia and multiple blood clots in both lungs. And it was a pretty painful experience of being in a hospital for a week before they discovered this stuff and were able to start treating it and put me on blood thinners and so forth. I had to wait for a while. They also started right away with the day after shot at that point. I can't remember the name of the drug, but and then they did reduce my dose, and I want to say that they reduced it by 20% for the rest of the regimen for that. And I finished, I got through it, through the whole scheme of the chemo, and it worked. And it worked pretty good for a while. As far as after the chemo or even during it, another thing I had was my legs felt like two telephone poles. I could get up in the morning, I could, you know, if I was sitting for a period of time and then I go to get up, like for sitting at a table in dining, and then I would go to get up, I'd have to very slowly, or I'd, you know, go down. But the diet, one of the things Peter said too about the metallic taste, I just started using plastic utensils when that happened, and it seemed to help a little bit. I don't know if it was psychological or not, but it helped a little bit.
What's your age, Dennis?
I am 74 at this point. I was
Okay.
70 when I started, I believe. Yeah.
No, you're not that much older than me, so.
16 when I got my chemo.
No.
So I want to keep moving here because we've got about 4 people. Ken or Barbara, is there anything you'd like to add to help Steve?
I can't think of anything other than to consider those ice on the hands and feet to prevent. It's a nuisance, but it is harmless. And also just to go into it, not knowing what's going to happen, because everybody's going to react differently. As I think, I don't know, earlier there, we mentioned Mary didn't react to docetaxel, he reacted to carboplatin. So just to keep an open mind.
Yeah,
you might be fine.
You know, all I can add is that, you know, I was 56 when I did docetaxel. I did 6 rounds every 3 weeks. I really didn't have any problem. Of course, I lost my hair. I didn't put an ice cap on, but the ice caps, the professional ice caps do work. I mean, Cameron in Australia had one. It freezes your head and it's painful and not a lot of fun, but he didn't lose his hair. He's got 3 young boys. They didn't want him to see him, you know, they wanted to see him sick. So he didn't do anything on his feet and hands. He didn't get neuropathy. I unfortunately did get neuropathy in my feet because I didn't use ice. And today I'm not doing it. I'm doing docetaxel again. I'm not going to do the ice because I already have neuropathy. But if I had it again to do without neuropathy, I'd probably do the ice on my feet and possibly my hands. Neuropathy isn't, you know, it's not terrible. I take gabapentin and it pretty much is, I don't even notice it during the day, but I would still probably do the ice. I noticed a little different than Peter. I noticed the metallic taste the first day, you know, but it went away and I kind of had a normal diet. I did find though after like the second and third round that constipation was a problem. So I drank like half a bottle of prune juice the day before I would go in for chemo, and that pretty much resolved it. But I found it to be cumulative. You know, the 5th and 6th rounds for me made me a little more lethargic, but I was always pretty active. I went for hikes after chemo, just to kind of keep my mind okay. So I think you'll handle it okay, and it'll actually bring your PSA down, and it works pretty well. But losing hair is pretty normal.
Your neuropathy disappeared between the last round and this round. Once you get off, it goes away.
It doesn't disappear. What it does is it gets kind of muffled by gabapentin. You know, gabapentin is a nerve. I don't know what it is actually. Lynn probably can tell you, but it blocks the nerve pain. So I don't really notice the nerve pain. I take 3 pills a day, 2 in the morning at 1 night. So, but if I had it to do over again, I would do ice. You know, I would do exactly what she said. I'd do ice bags on my feet for sure. It's
No, good
not.
advice. Good advice. Thank you.
Okay, so I just want to say that that you can also get neuropathy from long-term use of ADT, which I did. It's not as common, but it can happen. So, for Ken, it could have been a mixture of the ADT, and it could have been partially ADT, it could have been partially the chemo, but the gabapentin can work. I want to keep moving along, and I want to answer Peter's question, and then we've got 4 people left to visit with. Peter asked, why is the development of cancer treatment, particularly prostate cancer, I assume, not producing any new types of chemotherapy? And Len, do you have some thoughts on that for Peter?
Yes, but let me first make sure we're talking apples and not apples and oranges. Peter, I'm getting feedback on your end. Could you mute yourself?
That's better? Is that better?
No. Just while I'm talking, just mute, and as soon as I stop, you can turn it back on. So, okay, and this is from a pharmacologic point of view, what we mean by chemotherapy is a cytotoxic drug. Cyto meaning cell. So this is toxic to all cells, more toxic to rapidly dividing cells, which is typically the cancer cells, the most rapidly dividing cell in your body. But your hair follicles are constantly renewing and growing. Your mucous membranes in your mouth are constantly changing, and that's why people get mouth ulcers, mucositis. So that, first of all, that's what I'm talking about. When I say chemotherapy, I'm talking about cytotoxic drugs. They're not at all specific, like we have a lot of specific or precision medicine drugs today. So first, why aren't we producing newer chemotherapeutic drugs? Because cynical view, drug companies can't make a lot of money on those drugs because it's a 6-week course, or whatever it is, however many cycles, and you're done. Compare that to hormone therapy, which Jake's case, he's been on it for 8 years. It's a never-ending stream of money for them. Just also, this is one of the reasons why we have problems producing new antibiotics today. You think about it, if you get sick, you have an infection, they give you an antibiotic, done. You're not taking that drug anymore. Okay, so there's the money angle. The second thing is, let's face it, as we've just heard everybody saying, it's not fun to be on those drugs. They have all kinds of side effects. I don't want to go over that again. We just did that. But, it's just the nature of that type of cytotoxic therapy that it's never going to be selective. All it's doing is killing any cells that are rapidly dividing. And there's, that can't change. So that's why we have, precision medicine now, the BRCA drugs that only target, one pathway, and they don't affect other cells or other metabolic processes. So that's my answer.
Okay. Peter, you can unmute.
Very good answer. Excellent answer. I just keep thinking, docetaxel has been around a long time, and I don't know. It seems like it's worth doing research to find something that has, if you're going to take a poison, to have a little less effects on some things. But I guess it's money that talks. Yeah. Thank you.
Well, somebody else did have that idea, and thanks, Peter. I think it was AstraZeneca, and they produced Jevtana, cabazitaxel. They wanted a drug that was less toxic than docetaxel, and they came up, and that was probably around 2012. I think docetaxel was first introduced about 2004 or 2005. So it's been around, but it hasn't been around a very long time. Anyway, I want to keep moving on so we get around everybody. Joe Merger, turn on your mic and tell us what's on your mind. You might just want to remind the people here about your situation. I know Len wasn't here last week.
Okay, Casodex for about a year, off and on. The side effects get to me. I just feel funny, and I've been back on it now for about 2 or 3 weeks, and seems to be going okay. It brought my BSA down from 929. When I go on vacation, it comes back up. But I'm comfortable for what it's doing for me. I started Casodex a year ago. For the 16 years before that, I didn't take anything. Anyway, that's a quick review. Last week, I brought up my doctor wanted me to take a I can't remember what it's called. The Myriad test.
The Myriad blood test, is that what you're thinking of, Joe?
Yes. And I did get approval for it. I don't know what it costs, but I just got a letter saying I'm approved for it. Is there any reason not to take the test or to take another test instead?
Good question. And I want Len to take a shot at this too. I think we asked you last week, and you told us you had significant family history of cancer. Do you have kids?
Yes.
And boys, girls, a mixture, or one or the other?
Both, yes.
Both.
2 boys, 3 girls.
Well, what you really, the first thing you need to know, and especially since you have a significant family history, is if you have inheritable gene mutations. In other words, whether you've inherited a gene mutation and whether you're likely to pass a gene mutation on to your kids, because your kids need to know. Secondly, you need to know whether you have any mutations which could have been inherited or might have made yourself. And we call those somatic mutations, SOMATIC. Maybe, Len, could you just put germline and somatic into the chat window for Joe for later? Thanks. Now, the Myriad test, I'm pretty sure, doesn't tell you whether the mutations are somatic or whether they are germline, which means that if you do have a inherited mutation, you're going to have to test again if you want to be able to tell your kids. Now, what we would suggest is do a germline test first. It's a lot less expensive. Your doctor can order the germline test, or you can order it yourself. It'll probably be I don't know about your insurance. It might be a little cheaper if your doctor ordered it, but if you order it yourself, it's going to run you about $240. It might run you less than that. Depends on your insurance if it goes through your doctor. That will tell you whether you've got anything inherited. Then after that, do the myriad test or do the foundation medicine test. Because then you'll know whether any of those mutations are inherited. Does that make sense to you? Are you following me?
I think so. I'll have to look at Len's post about germline and somatic. That'll help me out.
Okay, if not, you can call us. You can go to our website. There on the AnCan website, there's a whole presentation on this. If you put in germline mutations in the search window, or somatic, or genetics, put genetics 101. I think it's genetics 101, and there's a whole presentation from Professor Bill, God rest his soul. But the reason why I wouldn't start with a myriad for you is because you've got a significant family history, and you're going to need to know which of those mutations are inheritable, and the myriad test, I don't think, is going to tell you that. I mean, you can ask your doctor, will it tell me which mutations are inherited? And if he says yes, then go with it. If he says no, say to him, well, I would prefer to start with an inheritor, with a germline inherited test. Germline and inherited are the same.
Rick, my understanding is that the myriad genetic test is really meant for guys who are newly diagnosed. They're low risk or intermediate risk, maybe even favorable intermediate risk. So 3+4. And their test is supposed to give you probability or odds, how likely it is that your prostate cancer will metastasize or not. So how aggressive might it be? And that's all it's really good for. If, let's say in my case, I had high risk advanced prostate cancer, doing the myriad test would be useless for me because obviously I had an aggressive tumor and it had already metastasized. So it would be wouldn't be helpful at all. I don't know all the details about Joe's case, if he already has Mets or not, but it's really for guys who are newly diagnosed and want to know how aggressive does their therapy need to be.
Now, I thought Myriad offered a test that is also equivalent to the liquid biopsy that Foundation Medicine does, Len.
Oh, okay. If that's the case, then I apologize. I was not aware of that. I was only aware of the type that I was speaking of. So
Yeah,
you may be right.
And you may be right too. I don't know. I think, Joe, what that means is that you must also check out with your doctor exactly what this myriad test is doing. Because I had understood that the myriad test was going to tell you what mutations you carried. Len's thinking that it might do something different. So what we need to know with you is what mutations you carry. That's what the test has to answer. So I'm just, I mean, they do have, I'm just not sure what tests, I don't know what tests they offer. I'm looking at their website right now, and it's sort of hard to do at the same time as trying to run this. But I do think that they, yeah, they do run a test, the prequel test, which is the one I think that Len is thinking about, which is to, let's see, where's that test? I think that prequel test, is that the one? Where is it? Let's see, prostate cancer. Let's see what it says for prostate cancer. Polaris. Okay, so no, not prequel, Polaris. So the Polaris test that Len is thinking of is used for men after they've had surgery to see what the likelihood is of recurrence. That you don't need. But Myriad offers a bunch of other tests too, and I think they may offer a test that does what we need for you, which is tells you what mutations you carry, but doesn't tell you if those mutations are inherited or if you've made them in your own body. And so I think,
Rick?
yeah.
So my notes, I have notes I took some time ago, and it says that the Polaris test from Myriad Genetic Laboratories is the one that is used to assess risk for low and very low risk forms of prostate cancer at the time of diagnosis.
Oh, okay. Sorry, I've got them confused. Thank you.
And there are a couple of other tests in that same category. The Decipher test from Genome DX, the Oncotype DX test from Genomic Health. Yeah, so those are the kinds of tests I was talking about.
Right.
And yeah, so
right.
I don't know about any other Myriad tests.
Well, they do run a whole bunch of other tests, and I thought they had a genetic, I thought they had a test of everything. But Joe, I think what you've got to ask your doc is what tests are they sending you for?
Yes. We'll find that out.
And the test that you want is, you want them to, I think Ambry is one of the providers. Color is another of the providers. Who else does germline testing?
What's it? Oh gosh, I just had it done. I can't remember the name of it.
Yeah, there's a couple of others, but just tell him that I think you go back and you tell him, if it were me, I would go back and say, I want a germline test done first.
I think the one did mine was Antiva. Antiva.
Antifa? We're in it wasn't Antifa. We're in trouble if it's Antifa.
It's INTIVAE. Antiva.
Okay. Yeah, I think that's another provider. Okay, Joe, come back next week and tell us what he says.
Okay, thank you.
Sure. Larry Fish, welcome. Nice to see you as ever. Well, we can't see you.
Well, nice to hear from you, Rick. What did somebody tell you that I was here so you didn't just go over my name and miss it?
As it so happens, I did see you arrive, but I have to say, that somebody did point it out. I won't say who, but I had already seen you here.
RJ.
Jay, uh-oh. All right, somebody made you an organizer, I can see. Okay, anything you want to talk about today, Mr. Fish?
No, I'm good, thank you. You know, I mean, this morning I was thinking about COVID-19 clinical trials and what's the likelihood for someone with a advanced prostate to try to get into one of these, vaccine trials, because I don't really want to interact with people until I know something is really like treatment or a vaccine. I mean, do you think these are like trials where they would want to get a broad section of everybody in the population?
No idea. Len, do you know anything about this?
Are you talking about the test for the coronavirus or the antibody to the coronavirus, Larry?
Well, I'm thinking about the vaccine trials.
Oh, the vaccine trial. So they only, let's see, I think
Stage
that,
3 trials that are starting.
yeah, I'm not really 100% sure. I think that there are several different trials. Some of them are giving the vaccine to healthy people who are not infected with the intention of later challenging them with the virus to see if they develop COVID-19 or not.
I was
But there might,
wondering, there's the other, which is the epidemiological version, where they just give it to everybody and then take a sampling of them compared to the population. Trace that. That takes longer.
yeah.
There is a speculation that people on ADT may have some kind of resistance to the COVID. I think we talked about that very briefly a couple of weeks ago. And I forget the gene that it affects. But those of us on ADT might actually be in better shape than those who are not.
That's true. Yeah, there's something called the TMPRSS2 protein, which the virus uses to enter cells. And so guys on ADT have lower levels of that particular protein, so it makes it more difficult for the virus to get into the cells.
Thank God for your memory, Len.
But I don't know, did they do a study of that, or that's just because of the way that they just see that, it's usually the cytokine storm that kills everybody.
No,
it's observational, Larry. In Italy, they noticed that men who had prostate cancer were infected at very low rates, or if they were infected, there were very few hospitalizations. Most of them had mild cases. And there's a clinical trial going on right now involving, that they're actually going to be giving ADT drugs to men they don't have prostate cancer, but they have the virus infection, and they're giving them ADT to see if it moderates the intensity of the virus of COVID.
I'm still thinking about getting a vaccine as part of not waiting a year by entering a clinical trial. One of those where it might be a controlled study, but they have some that are not controlled. And I didn't know if anybody knew anything about those variations of.
I don't, but what I would suggest you do is call PCF and ask them, because they are really up on this. They're sponsoring the trial at the VA with Firmagon and the Tempris, but they're really up on it. So I would call their 800 number. And in fact, I think I've even seen in some of their literature that they're available to talk about that, and just call and tell them that you are, you might be interested in a trial, but then you might be prejudiced because you're on ADT.
Yeah, good point. I was thinking of calling my oncologist at Sloan, but
Start with PCF.
Yeah,
You may learn more.
I may find out that it's not eligible.
Yeah, start with PCF. Okay, I'm going to keep moving, Larry, because we've still
Sure,
got.
I didn't know why you like asked me if I wanted to talk. I thought like you'd run out of people.
No, I was going to come back to you, but that's okay. If you wanted time, I was going to make time for you. Otherwise,
No, I'm done. I'm done.
you would have been giving me trouble next time. I know.
Well,
Okay.
the pot calling the kettle.
Oh, I see. Okay. All right. So Les, what's on your mind?
Well, I just wanted to comment. I had taken another blood test, and they've been taking them every 6 weeks. And the testosterone is the same as 6 weeks ago, I think it was about 427. But the PSA has gone from 0.2 to 0.4. And that's about it. That's about all the information I've got right now. But anyway, it's on its way up apparently.
Over what period is this?
6 weeks.
6 weeks. Well, you know, the issue here is just to keep a close eye on it. Anybody want to, Len? What's your thoughts for Les?
Yeah, continue monitoring the PSA. Once you get above, or if you get above 1.0, then you get within the detectable range of the more sensitive scans like gallium-68 or the PYL trial that I was in and that Rich Jackson is trying to get into right now. I know you're seeing Dr. Kwan where he likes to use choline scans, but I don't know what they do now. There was a time years ago, I remember, where they wouldn't even take you for a choline scan unless your PSA was over 2.0. So I don't know if you want to wait that long. There's an FDA approved scanning that's better than the choline scan. And it's, yeah, like I said, the PSMA scans I mentioned before, you have to get into a clinical trial. But Rick, Jay complimented of my memory, and now I have to tell you, I can't remember the name of the other drug, but Rick, you'll know it.
Axumin.
Axumin, thank you. So Axumin is not as good as the PSMA scans, but you have a chance of picking up, lesions once your PSA is over about 1.2 or so, 1.4 maybe. So that's those are my thoughts on that.
Okay, by the way, I did contact Dr. Kwan's office as soon as I got the results, and they immediately signed me up for another scan, C11 choline PET scan, and an office visit in early August. I think they were anticipating it going up because normally once mine starts up, PSA doubles about every 6 weeks. So I think he's anticipating where it's going to be by the time I get there.
Okay. I would ask him why not try, if August comes around and your PSA is still less than 2.0, which my understanding is that's the bottom sensitivity for choline. Ask him why not try Axumin scan instead. At least talk to him about it.
Yeah, he had mentioned that before, and I'm not sure if they have that there. But as I mentioned to you in the email, that Iowa City, Iowa has that now, and they're only a little over an hour drive from here. So I've been trying to look into that. That's all I've got.
Well, it's enough, Les, and you know, I think the biggest issue here is to do exactly what you're doing. Keep a close eye on it, and then try and get decent scan. I mean, if the choline shows something, fine. If it doesn't show something, then think about an Axumin, or think about trying to get into one of the trials that may be open by that time. So, and you're saying also that your testosterone hadn't moved much, so it's still what, around the 400 level?
476. It was identical number as
Okay.
6 weeks ago.
Okay. Okay. Well, that's good news, but you know what's less good is that the PSA is on the rise. I mean, you also may be a very good candidate for intermittent. And if you are, we'll talk about that maybe in the next meeting, because we've had, you know, Len's the intermittent star, Peter's done intermittent. You know, it may be worth discussing that. But whether Dr. Kwan would agree to putting you on intermittent, that's a whole nother question. I don't know. I don't know what his position is on that.
Okay, thank you.
I want to visit with John, and then I want to visit with Barbara at the end, because I know there's a real interesting question, and Barbara and I caught up today, so we've done some talking. John Hall, what's on your mind?
Well, I finished my proton beam therapy, and it went pretty well, but I am still sore sitting. I'm having trouble sitting for longer periods of time. I mean, for more than about 10 minutes at a time. I try using a ring and pillows and different things to help, but for the most part, I'm either more comfortable lying down or standing for periods.
And you did the proton beam at Mayo, correct?
Hello? Hello?
We're here. Can you hear us?
Were you able to hear me?
Not too well. I'm going to repeat what you said. Did everybody hear, or do I need to repeat it?
Please repeat.
Yeah. So John finished his proton beam therapy at Mayo in Phoenix about I think he said 4 weeks ago, but he's having a lot of pain sitting. And he's tried sitting on a ring, but he's still having pain sitting. John, is that the summary? Are you with us, John? Are you there? It looks like we've lost him.
He's listed twice.
Yeah, I know. I'm not sure what. I think
Shows him as muted.
Yeah, but I think he came in and then he came in again. I think he was having trouble the first time.
What was this his primary therapy, Rick, for the proton beam for the prostate?
Yeah, it was primary therapy, but let's wait until he comes back. He was, as I recall, he was de novo metastatic. John Hall, isn't that right? Wait a minute, Mr. Anderson knows about. Wake up, Ken. Hello.
I have been sleeping slightly, but he was, or he is de novo metastatic.
Right,
I'm
right.
not sure why he'd be having problems with the rectum unless he's got hemorrhoids or something.
Yeah.
Not sure. I'm not really sure. He's back on now, though. Hey, John.
Are you with us, John? Can you hear us, John? Your microphone is off right now. John, what you might want to just call in if you're having trouble with the internet.
You mean the wrong way?
Are you there?
I can't.
All right. Here's what we're going to do. We're going to go to Barbara, and then John, if you can hear us, we'll come back to you after Barbara. We will not close the meeting without coming back to you. Barbara, maybe you want to do a quick update of where Barry is, and then you had this really interesting question that you asked me, and I'd like to see what Len thinks. Do you want to just outline?
Yeah, okay. Yeah, my husband Barry was resistant to docitaxel and then Xtandi, and it looks like he's not doing that well on carboplatin, cabazitaxel as well. And we're looking at other options. And he got his Foundation 1 test. He got both a liquid and a. Can you hear me?
Yes.
Can you guys hear me?
Yes.
Oh, good, because
Yes.
my internet sometimes behaves. Good. Okay, anyway, he got Foundation 1 tests, both liquid and solid biopsies, because they had trouble getting a solid biopsy from the first time. So this time they ordered both a liquid and a solid sent to Foundation 1, so that we could further see if he's eligible for any other further kind of therapies. And his PSA doubled, and it was confirmed with scans. It is growing. It's all bone at this point, but we don't want it to jump off that. He lights up like a Christmas tree when you look at the scan. So anyway, he had interesting results. The liquid biopsy, among other things, turned up an ROS1 fusion, which is treatable sometimes. It's a tyrosine inhibitor kind of treatment, which you don't really need to know what it is, but suffice to say there is something specific entrectin and possibly other things that could be used. However, when the solid biopsy was done, it did not show the ROS1. It showed a few other things. It showed AR. None of the usual suspects, BRCA or the PARP, showed up in it. So, that's basically his only option. So we spoke to several people. Rick put me in touch with Ellie Van Allen, and we're now getting a consult with Dr. Sweeney at Dana-Farber, who we're thinking of switching to. We're also looking for what you'd call a center of excellence main oncologist at this point. Our local people are wonderful, but they're limited. And so we're looking at several interpretations. Dr. Joellen Murphy of Court Foundation 1 called me today, and she thinks that sometimes if bone is hard, the solid one actually doesn't pick up everything. I was under the impression the solid would pick up everything the liquid did. She said sometimes the liquid could pick up something that the solid doesn't. And it could be there. This talk, we're going to see if Sweeney wants another biopsy. We don't know yet. Meanwhile, Rick sent me this lovely email that normally, for a new study that says that generally bone metastases are homogenous, meaning that if they didn't see it in this, they won't see it in another one. So we're looking at what to believe, essentially, whether there's more testing, and whether to be looking at whether that ROS1 might be a false positive, which the doctor at Foundation 1 doesn't think it is. But we don't want him to miss a good treatment if it will help him, because the standard of care is not working. But we also obviously don't want to treat him for a mutation that's not there. So we're looking into all aspects and taking all opinions on what to do. His blood test, by the way, is coming back to see how his PSA and other things are doing on the docetaxel, but our hopes are not high. So there we are. Have I explained this, do you think, reasonably?
Yeah, I would say I'll just add a couple of quick things, which is that, and I'm just putting a link in the window for everybody. This isn't the study. This is a report on the study that was in the magazine, so it's very, very readable, by a guy called Peter Nelson. This is from 2016. We talked about this at the time, but what they found,
I just read it, by the way.
What they found in prostate cancer is that whilst the disease is very different between men, very heterogeneous, within the same man, most bone mets look exactly the same. So if you were to sample a bone met from your hip and a bone met from your femur or your shoulder, it would probably look exactly the same. And I think that's true of soft tissue too, but I'm not certain. And that's unusual in most cancers, because in most cancers that they're not homogenous, they're very different. And this came up because the doc at Foundation Medicine seemed to think that the bone mets could be different. Bone mets would show different things, but we don't think that. She probably wasn't aware of this research, and we don't think that's the case in prostate cancer. And this article, if you click on it and save it, it's easy to read, and it's kind of interesting. And then, and as Barbara says, this ROS1 does respond to something called a tyrosine kinase inhibitor, which is used quite often in lung cancer. But you don't want to treat somebody for this if they don't really have it, and we're not 100% sure that Barry has this or not. And that's why we're sort of working to ascertain whether this is the case or not. ROS1 only occurs about 1.5% of the time in prostate cancer, so it's not very common. But Barbara had another question for me, which I think is a great question. I can't really answer it. Probably Peter Nelson, who did the study, could answer it. And the question was, how can all the other bone mets in your body be exactly the same? Because how do they conform with each other? There's got to be a time when they're out of sync. So they may all tend to be the same, but there's got to be some time involved here. And I said, oh, I can't answer that. I'll have to ask Glenn, because it's more of a pathological question.
Can I elaborate quickly? What I was trying to say was that if cancer mutates, which we know it does, how can it all mutate at the same time? Because clearly cancers become resistant, which means they're changing, and I just can't see a button being pushed and everything from his femur quite up to his skull, which is where he has it, suddenly it's all changed. So it doesn't make, I can see that the study said it, at the same point it doesn't really make enough sense to me. So, I mean, obviously Foundation One's checking into it, Dr. Sweeney's checking into it, Ellie Van Allen's, everyone's weighing in. We all got all of this information over the last 2 days. Right. So I have enough of a science background to know this is quite interesting. And it's, well, what can I say? This is my husband's treatment.
I'll give Len a brief reprieve and go to Ken Anderson first. Ken, you have a thought on this?
No, well, I just wanted to mention that I had a conversation with Paul at MD Anderson just about this, whether or not the cancer, when it moves into bone, whether or not it's the same. And his and their belief is that it is not the same.
Well, it's not the same as the primary.
No, even amongst bone mets, they're completely different. You could sample, his comment was you could sample one on your hip and one on your femur,
You've
and they
just
wouldn't
frozen on
necessarily
me.
be the same. I can't hear you, Barbara.
I think Barbara's having internet problems because we just froze. No, we can't hear you, Barbara.
I'm
You're,
going to have to call in too. Sorry.
just turn.
I'm going to have to call. You guys are getting. Can you hear
turn
me?
your video off.
I'm
Just
going to
turn
have
your
to
video
call
off.
in. Okay.
Turn your video off first. Now try. Nice try.
She laughed. Yeah, his comment though, Rick, I can tell you because I had the same conversation with him because I was talking about having, the biopsy from a part, my hip someplace, wherever they could grab it. And his comment was that they would expect them to be different. Not only,
Well,
go ahead, Bill.
read the.
I will. I'll read it. I will. I saw you
actually,
posted it. I'll take a look at it.
and there's also I've also got the journal study for it. I'll put that in there too. Len, what are your thoughts on this?
Well, I think that we're getting the impression already that this is a gray area. There isn't a lot of agreement, even among the experts, whether or not metastases are all the same or they're different. I remember from that article by Nelson, their speculation was that not every cancer cell is capable of metastasizing. They have to undergo something they call epithelial to mesenchymal transition. So they have to, break out of their comfortable, normal environment, pass through something called the epithelial barrier, and get into other types of tissues which normally might kill them, but somehow they survive. So they're thinking that those cells that do manage to metastasize all have some common characteristic, some common genetic basis that enables them to do that. So I think that's the theory behind why the genetics of the metastatic lesions are similar, if not identical. But that's not actually, as we've just heard, that's not 100% accepted. It's still controversial. Just like so many other areas of prostate cancer, we don't have answers yet.
Wouldn't that argue in favor of the liquid biopsy then, which is a systemic testing of cancer cells, rather than specific metastases? The liquid biopsy might be better, I would think.
Well, you have to think about where the liquid biopsy is, where those cells have come from. So when you do a liquid biopsy, they're basically sequencing cancer tumor cells that are in the blood that have sloughed off metastases as they've died. As the metastases have died, these cells have come off of those lesions. So you might be getting, you don't know where that cell came from. You don't know what part of the body that cell came from. If Pete Nelson is right, it doesn't matter because they're all the same. But if he's wrong, then the liquid biopsy is really only a solid tumor biopsy, except you picked up the sample from the blood rather than getting it from a specific site.
Yeah. So you're saying then that does not, that is or isn't valid, or maybe it came from the prostate.
No, I'm not saying it isn't valid. It could well be valid. It's just that we don't know where it came from. Could it have come from the prostate? Could it have come from a tumor in the prostate? I suppose so. It would have to somehow or other get out the prostate and into the bloodstream. I don't know physically how it That's above my pay grade, Barbara. You'd have to ask Dr.
Okay.
Sweeney about how it can get out and into the bloodstream. But Len?
Yeah, there are a lot of variables. Barbara, when my biopsy of the prostate was first genetically sequenced, I had 7 mutations. Recently, I had a bone lesion that was biopsied and sequenced, and instead of 7 mutations, I had just 1. That one was also one that was in my prostate, but it was just 1 of 7. So what happened to the others? My oncologist said, well, possibly this is just a sampling error. He says when they do a biopsy, they're taking a very small amount of tissue. So it could be that, the cells that they happen to have biopsied could have been different from cells that were just a few millimeters from that site. And if you had done a biopsy of the site a few millimeters away, you might have gotten different cells with different genetic mutations. So I don't know if you were on the phone when you heard me talking before, but these are just areas where there isn't a lot of agreement. There's a lot of gray area and a lot we don't know. Unfortunately, we don't always have answers to the questions that we'd love to have answers for.
No, well, in that case, a thorny decision, I'm sorry, needs to be. What can this is recorded, right? Okay. But anyway, a THORNY, not,
You got it.
keep the T in there. A decision needs to be made then, I mean, whether to, what to do in terms of treating Barry, and that's why we want to check it. And again, when you say they caught 7 mutations once and 1 the other, that sort of again is saying it's not homogeneous, because theoretically, if it's homogeneous, then it wouldn't matter whether it was a millimeter away; it would all be the same.
No, but
Am I wrong? What am I missing?
Where we picked up 7 mutations, that was from the prostate. Where we picked up 1 mutation, that was a bone lesion. And what the article that Rick brought up was saying that it's the bone lesions, metastatic bone lesions, that would be homogenous, not necessarily what you find in the prostate.
Oh, I didn't get that. I'm sorry. I thought that what you had said was that they were both from the bone lesion.
No.
That makes more sense.
No.
Yeah. Anyway, listen,
there may even be material from Barry's original prostate biopsy that might be able to be looked at. Would that make sense? He had it done in September, but he had a prostate biopsy when he first was diagnosed, and I imagine the tissue is still around. I don't know if that might shed light on it or not.
It's relatively recent, but I mean, I think that would be a Dr. Sweeney call. Normally we say no because it's much longer. In this case, it's maybe just over 6-8 months old, so it may not be bad, but I would say that's something that I would defer to somebody like Dr. Sweeney. We must move on because I promised I'd get to John Hall, and we're using this room again in 20 minutes, so we've got to close out. John, can we hear you this time?
Yeah. Oh, I do want to add a thank you to everybody, by the way, before I sign off.
Yes, I can. I can hear you guys. I've been having very bad. I've tried with the desktop, and now I'm on my cell phone. Hopefully, it's working better.
So let me just summarize what I heard you say, and then we'll just get some quick feedback for you, which is that you finished your PBRT at Mayo about 4 weeks ago, and that you've been having significant issues, and it's tough to sit down even when you're using a pad. Is that pretty much it? It looks like you're muted again. You were there and then now you're muted, John. Are you with us? Are you with us or are you against us? There, you're back. Are you there? Are you there, John? Microphone is green. Say something. Okay, I would suggest.
That was Barbara.
And that was Barbara. Are you there, John? No. I think seems like you're having issues. Probably the best thing is to call in on the dial-in number, but I'm going to have to ask you to do it on Monday because I've got to close out the room so that we can turn it around. I'm so sorry. We're happy to give you suggestions on the problem if we have any. I think we understand it. In case John can hear, is there anybody that wants to say anything right now on that issue quickly?
Well, I would just reiterate what Ken Anderson said. It sounded a bit like it could be hemorrhoids or some rectal issue that's causing his pain when he sits. Just a speculation.
Yeah. I mean, definitely it's something that should be raised with the. It should definitely be raised with the radiation oncologist, and then let him refer you. So I would get yourself back into that Mayo system and see if they can figure out what's going on, John, and not wait. I don't see that it makes sense to wait. Okay. We're closing out. This will be posted tomorrow sometime in the morning, my morning. You'll find it. If you want to listen again, if Barbara wants to listen to what she missed, or she may have gone, I'm not sure. Thank you, everybody. It was a smaller group, but a good session, and we still didn't finish on time. Okay.
Well, so long. I'm still here, and I'll listen to what. Of course, my internet went off just when you got to me, so at least I'll play back and listen to all the wisdom that I missed. And thanks all of you.
Okay, pleasure. Okay.
Thanks, Barbara.
Bye, everybody. Good night.
Good night.
Good night.